Oh, connection.
Are we
Hello?
Hang on 1 second. We might have a technical difficulty. Can we see? Because you're frozen. Before we get off here.
Oh, there we go. Let me see.
I think she's on.
I might
Please
do a
hold
last.
everyone. We have technical difficulties. We're gonna get
switch over for whatever reason. Sometimes let's see.
You just fix that. I'm going to keep talking really quick. Dr. Merritt has some technical difficulties. She'll pop back on. Oh, there she is.
There she is.
Okay. Does that work? Okay.
Hey, everybody. Welcome back. Happy February. I am Sarah. Before we get into our amazing interview tonight with a really cool chick and happens to be a doctor, I'm going to turn it over to Amy and Tara. Amy, they both have some stuff we want to go over with you tonight before we get into this. But Amy, you take it away.
Okay, great. Hello. Thank you, everyone, for joining us this evening. We have a great presentation with our doctor. And that being said, we want to just call out a couple things. What we do is so critical in celebrating one another from a female standpoint. And that being said, if you have somebody that you know should be in the spotlight that we would love to learn a little bit more about, please tap us. Send us some type of formal communication. We will get in touch with that individual and move the dial. But bottom line, we want to highlight female superstars. And we know you know some, so send them our way. And also to keep in mind that we are all professional women. That being said, sometimes it takes a little bit of time to schedule things and coordinate. But when we do, it's fantastic. And bottom line, we work with any and all and different schedules. So just putting that together to bring it all to you. And again, thanks for joining us. Tara?
Yeah. Well, as y'all know, we love to make these interactive and hear from our audience. So if you have questions for our guests, don't hesitate to type them out. We are here on Facebook and YouTube as well as Instagram. And so we are so excited that you're here. And we'll make sure that any questions that come in from people watching or listening later on, that we'll be sure to highlight them or answer them as they come in.
All right, so let's get to the good stuff. Nobody wants to really talk to us three. We always want to hear from our guests. This is always, I love when we have somebody that somebody else knows, but Dr. Lindsey Merritt, her younger sister actually works out with me and Tara. And then Amanda, she's listening, I think, tonight. And Kristen, I actually had to go in and had stomach issues, had a colonoscopy, and they both highly recommended her. When I was there, I can't tell you guys, she was so cool, like so cool. And I'm like, so I asked her sister, I need to have her on the show. And she tells us all these good things about you and like how you're thriving in life. And I'm like, we got to pick her brain, hear how she's doing. So welcome, Dr. Lindsey Merritt. How are you?
Thank you so much. I just want to say that it's such a pleasure and it feels like an honor to be here. And just the title of your community, Thriving Females, it's so empowering. And so I'm just really honored that y'all wanted to talk to me tonight.
Oh my gosh, yes. So tell us a little bit about yourself. We know you're a doctor. Why don't you tell me you're a doctor, family, kids? What do you do?
Sure. So my name's Lindsey Merritt. I'm originally from Southern California, but have moved all over. So spent some time in Minnesota. That's where I met my husband and graduated college, and then did my medical training sort of all around the U.S. A lot of my training was done in the Northeast. I went to med school in Arizona, and then finally, after graduating fellowship, moved here to Jacksonville. And so here I'm in practice with Borland Groover. We're a big GI group in town. So it's an awesome group of doctors they get to work with and be colleagues with. And personally, I'm married. I have a husband and I have two beautiful kids. I have a daughter who's turning 1 in 3 days. Can't believe it. And I have a son who is 4 and he'll be 5 next month. So Sarah, when you asked me to send you some photos and just, show kind of life and hobbies and whatnot, I'm like, I can't I can't even find photos, without my kids. So these days, that's a lot of what occupies a lot of my personal time is just spending time with family and Kristen, my sister, and siblings and parents included. We all live really close together, and we're all pretty close knit family. So that's what I do mostly in my free time. But I also love to cook. I love to be outside, doing anything outside. I'd say that I love to garden, but I've rarely successfully grown many things. That's like I'm striving to be a really good gardener. And what else? I mean, travel and be outdoors. The ocean is one. Oh, where did you find that? Okay, that's hilarious. Speaking of the water, I love to water ski.
We snuck some pictures because we
love that. Oh, that's so funny. Okay. Yeah.
I was going to say, I think there might be, oh, wait, we went the wrong way. There it is. There's some more outdoor stuff.
Love yoga. Thank you.
But don't you think when your kids are little and juggling being a doctor, your hobby is your family all of a sudden?
Absolutely.
That's what you have to do.
That's where my heart is, where I want to be 100% of the time.
So with that in mind, before we dive into your career and stuff, how do you balance your career and being a young mom?
So I think there's, I think most people would probably agree with us that it's, not so much a perfect balance, but there's some give and take, and some nights I'm working late, and then other days, I get done with work really early and I get to pick my son up from VPK. And, so it's just, kind of the ebb and flow, and overall just making sure that it feels like at the end of the week, feels like I've had enough time, especially with the kids. I know a lot of times it can be when I feel that stretch, tends to be maybe if I'm on call over a weekend, so I don't have that home time over the weekend. So that next week I'll try to compensate for it in some way by having, shorter days at work. And so really it's a lot of trying to balance time mostly. And then just being present, I think in both spaces. When I'm at work, I'm fully engaged and absolutely love what I do. So I'm there and I'm there for it and to have fun. And then as soon as I get home, just switching gears and leaving all of that at work and being home and just present and enjoying the chaotic bedtime routine.
Is that hard sometimes when you get personal with patients? Is that hard sometimes to leave it at the door?
I think yes and no. I think that, and I don't know if this is part of going through training. It's medical training. It changes your brain in such a way. This is my theory, that you sort of have to just on to the next thing. So I don't spend much time, dwelling or worrying about anybody. I feel like, I tend to, if there were say a patient that I was really worried about, I would tend to, just address it until I have closure and things are safe and stable. And then I feel good about, okay, I can walk away from this and go home or focus on something else. So it's, it comes up here and there, but for the most part, I think just being really conscious of, like I said, just kind of, taking that deep breath before walking into my front door, or same, going into work. It's kind of, okay, here I am, let's focus and do my best.
I need to go to medical training, so I learned to do that. So, Dr. Merritt, we're all dying to know, why did you choose GI? I'm I got to know why. Why would you do that?
So I think that my initial sort of instinctual interest in GI came from, like I mentioned, I love to cook. I love to eat. I'm really into all kinds of different foods and getting to experiment with making new dishes. And so I think that part of my interest in nutrition kind of drove my desire to learn more about the GI tract, and just really understanding the importance of your gut health is sort of the foundation of how you feel and allows a person to have a general sense of wellness or not. And it really just affects your quality of life so much. And I think, one of the things that's so cool is that we can totally address, our lifestyle and diet and have that really solve so many of our GI complaints. And then that translates into just better health overall. So that's my biggest, sort of what made me interested in GI, like as a med student, let's say. But then as I got into training and got more exposure, I just got really fortunate with having some incredible female mentors, strong female mentors, in my medicine residency that were both in GI. And so really I saw what they got to do on a day-to-day basis, and I got to learn from them and observe their procedures, and turned out that I love doing endoscopies. So it just sort of was a perfect fit all the way around. And there we go, in my element there, that picture.
So you say
What
your
is
favorite what is it? Endoscopy? How do you say it? Say it.
Endoscopy.
Endoscopy. That's down the throat, right?
So overall, just endoscopy means, so the scope in my hand there, that's the scope. There's a light at the end and a camera at the end of it. So using a scope to go anywhere up or down is an endoscopy. Now, if we're going to do an upper, we'll call that an upper endoscopy, or EGD is the abbreviation. And then if we're going to do a lower endoscopy, that's what's called a colonoscopy.
Oh.
So I was just going to say, in terms of best practices for our viewers, when should somebody kind of get checked out? Like, what is the standardized age range that is recommended, whether somebody has an issue or not? What does that look like?
So so speaking of, the different types of endoscopies, there's no standard, everybody must receive an upper endoscopy. That's based on symptoms and, specific instances like family history and whatnot. Colonoscopy, however, is a whole nother ballgame. Everybody deserves a colonoscopy.
And I love that you said deserves.
I know, deserves. That was such a good word.
Yeah.
Not exactly the word that I was like, yes.
I say that, and some patients look at me like, am I trying to offend them? But no, I truly mean,
No.
It's, you deserve to have your colon screened for colon cancer. It's just a no-brainer. We find small polyps and remove them before they ever become a problem. And, things that are left unchecked can progress and turn into colon cancer. So just like, for women having a pap smear, having a mammogram, colonoscopy is absolutely standard, starting at age 45. And now that, interestingly or concerningly, that age was recently changed. So it used to be 50 years old. Yeah. When you turn 50, you get a colonoscopy, and just in the past, it was very recent, like in the past 3 years, that was changed to age 45. And that's based on the increasing incidence of colon cancer in younger and younger people.
Okay.
So sadly, there was early in the COVID pandemic when nobody knew what was going on. So we all had gas masks on, still doing our procedures. So, but back to the colonoscopy, whether a person is average risk, or meaning has no family history, has no symptoms, no reason to think there's anything going on in the colon, everyone at age 45 should have a colonoscopy.
Because
thank you.
Yeah. Isn't this correct? Like it's the easiest to cure right away, or is that why say to get them earlier?
So it's based on the idea that, it's preventative health, and it's screening. So we want to either go in and see that your colon still looks great and you don't have any concerns. And then we feel very comfortable, saying, okay, you can come back in 10 years, or your colon, you're showing us that you're tending to want to grow polyps. And so generally speaking, when we can find those really early on, we can remove them very, very easily. When they start to get bigger, that becomes much more complex. And still, there's so many things that can be done endoscopically in terms of resection. But when it starts to, when a polyp, which is just a growth, think of it as like a skin tag on the inside of your colon. So it's a growth, or like a mole or something, but it's not dark colored. So it grows in your colon, and it's just going to keep growing generally until it's removed. So the potential to keep growing and progress into a colon cancer is there. Now, is every polyp going to turn into a cancer? No. Or maybe if given, 50 years of growth there, sure, certainly. But it's it's so simple to do the test, remove everything and give someone a really clean bill of health and let them know that, they don't have any concern, and we can do colonoscopies at the next appropriate interval, which looks like anywhere from 3 to 5 to 10 years based on the individual.
Excellent. Very good.
So I'm going to be the immature one right now because I don't think I could ever be a.
Dun, dun, dun. Do we need the drum roll? I know it's coming. I can just feel it. Go, girl.
I
You
just
go.
want to know this question. This is a need to know question. I don't know if I get a GI, so I couldn't keep a straight face, especially on a colonoscopy. So you reference it like how do you reference? Is it like butthole, anus, rectum? What are these? What do you reference it? We need the proper term.
Okay. So it depends who you're talking to. When I'm with my 4-year-old, I might say butthole.
I like butthole.
No, but so the colon it's like it makes an upside down U shape. So I could stand up to just be anatomical.
I was gonna say, are we gonna see your
up, across, and down. Up, across, and down. And over here is where the colon meets your small intestine. So all of that connects here. The colon then goes up, down, and then comes towards the exit on your left lower side of your abdomen. So when you get to the very bottom of the colon down there, that's what's called the rectum. And that's, it's called referred to as your rectal vault. And that's sort of a slight distension of the colon's, very tubular structure. And then you kind of get to this pouch. That's the rectum. And that's where stool is stored until it's appropriate and you're ready to have bowel movement. And then the anus is the actual exit point. It's sort of, you could think of it as like a short tunnel where the stool passes through. So you have two muscles, one on the inside and one on the outside, and both have to be coordinating and working succinctly to have an effective bowel movement and not develop pelvic floor issues.
So do you think that there's like should women be talking, not necessarily talking more about this, but really like taking care of this? Like, are you seeing more female patients, male patients, 50-50?
In terms of like from a colon cancer screening?
Just any of this stuff.
In
like
general?
Yeah.
So overall, fortunately, women tend to have a lower rate of polyp growth, but that is very likely changing with the younger and younger incidence of colon cancer. Because I'm a woman, I see, not majority, but at least 50% of my practice is female. And of my patients, I see, really advanced polyps very early on, where they're coming in maybe for another complaint entirely, even under age 45. And I'm like, we can work on your constipation, but I'm really glad we did the colonoscopy because I found, a big polyp that I was able to remove. So that's one thing, but overall, historically females tend to have lower rates of polyps. But with that being said, and speaking of, pelvic floor and all that, there's so much that, there are so many things that we can do to help women. We have a lot of different structures down there. We make babies and pass them through a lot of structures in our pelvic floor. And so that creates changes, and that can affect the function of your digestive tract and your ability to have really healthy bowel movements, which translates into other upstream effects, optimizing your microbiome and then
any red flags or things that women can be thinking about now that are like, I should probably get something checked out.
Well, so really like real red flags would be, certainly any bleeding, any pain with having a bowel movement, any sort of change in, if you've always been a person that goes once a day and then all of a sudden you're tending to be really constipated, or vice versa, you're having a lot of loose stool, those would all be reasons to definitely see your doc and just get checked out. But I would say also that, again, back to, women, female specific issues, if you're having trouble sort of having a bowel movement, or you feel like there's stool there but it's not coming out, or you're having any issues with like leakage or feeling like fullness down there, or things that can sort of suggest some pelvic floor changes, those would be reasons to also see your doctor, because there's probably a lot that we can do. And anything from hemorrhoids to pelvic floor physical therapy to, lots of possibilities and lots of things that can be assessed and done to manage those kinds of issues too.
So if somebody does have a polyp when you actually go in the scope and take a look at things,
Mhm.
so typically what do? You shave that off a little bit and then send it to a lab to better understand kind of the overall tissue and what that entails? Is that
Yep.
pretty
Yeah. So
fair?
that's a great question. Yeah. So um, what we do typically is to. So, I mean, I kind of call it like a lasso. So we use a device, generally speaking, if the polyp is sizable enough, we use a device called a snare. And it basically, it's a catheter and it opens up into like a generally circular, maybe hexagonal shape that will then, wrap it around the polyp, and then it sort of cinches closed. And in cinching it, we can either just sort of lop it off cold, or we might, if it's big enough, might use some cautery to cauterize the borders and remove it on a little bit of a deeper level. So that's like a standard polyp removal. There are much more like complex techniques that I do, but it's probably more than you want to know.
No, that's good to hear. Good to know though that, through that procedure,
Mhm.
that's what you're on the lookout for, and it's doable
Right.
to go in and take those out and
Yeah.
research them further.
Right.
Yeah.
Yeah.
Is it
So,
hereditary?
well, so certainly there's an element of genetic predisposition when it comes to colon cancer, especially in folks who have a first-degree relative that was diagnosed with colon cancer at an age younger than 65. That's sort of where we get to say, okay, you should be screened earlier. And what we do is screen them, do the colonoscopy 10 years before that family member was diagnosed. So you had a parent diagnosed at age 50, we should be seeing you at age 40 to really just stay on top of that. Now with that being said, genetics aren't everything, and one field that I really love is called epigenetics, and that's where you might have a genetic predisposition to this, that, or the other thing, or in this case to growing polyps or even to colon cancer. But there's so many things that you can do with your diet and eating a lot of fiber, avoiding processed meat, doing exercise, going and doing the, if I can swear, badass workouts that Sarah and Tara do out with my sister Kristen. So staying really physically fit and active. Those would be like some just generic type recommendations to reduce a person's risk, especially if they have that increased incidence.
So I'm still not mature enough. I've decided to do GI because I think I would laugh. I couldn't be serious at any of it.
Yeah.
So you're talking about weight loss. Now, some people might not think, oh, weight loss, I should go to a GI doctor. What would, if they're thinking about weight loss, like what would they expect when they, like some go to their primary, like I wouldn't think to a GI doctor, but explain that.
I wouldn't either. Yeah.
Yeah, I would love to, because, and thank you for that question, because so one of my specialties and area that I'm really passionate about is called endobariatrics, endoscopic bariatric procedures. And it's really a new field. New in medicine is kind of silly because these procedures have been around now for 20 years and we're still like, it's new and nobody's heard of it. But it's I should say it's now being able to be performed at sort of like a community population level. So again, what I do are endobariatrics. So there's a number of different procedures that are able to be performed with a scope and done internally, rather than to sort of spare someone who may not want to undergo a surgical procedure like a Roux-en-Y gastric bypass or a sleeve gastrectomy. Those are really invasive, major surgeries. Cutting through the abdominal wall come with a lot of risk and recovery. And so the endoscopic option is a lot more appealing to folks. And so that's where I'm really happy to be able to offer the procedures. The primary procedure is called an endoscopic sleeve gastroplasty. And
I
that's
feel like you
where,
just keep putting different parts of words together and you just make up these
Yeah.
words. I'm like, I feel like I just heard 4 different words there.
Can you change it?
so you can call it an ESG for short.
Oh, I like that better.
There you go. Acronyms are good. We can do that.
And an ESG is basically going in, with that same scope that you saw in that photo a couple of pictures ago, going in through the mouth, down the esophagus, and into the stomach. And when I'm in there, I'm applying sutures to the lining, to the stomach wall. And so in grabbing stomach tissue and pulling it together, I can cinch the tissue and kind of bunch up the stomach wall to create a smaller and tighter area, to mimic the anatomy that is accomplished by the surgical sleeve gastrectomy, which is where they go in externally into your abdominal cavity and actually, cut and remove 2/3 of the stomach.
So
Now, is that something? Oh, go ahead.
So I was thinking when you do that with the stomach, because
Mhm.
it can grow again. So if somebody has it and loses a ton of weight, is there still that option that if they don't take care of themselves and eat good, it can grow back bigger again?
Yeah. So the stomach is pliable. That's why we can do a lot of the endoscopic procedures that we can, is because that mucosa or tissue will, stretch and have some pliability to it. So if a person were to have, either a surgical procedure or an endoscopic weight loss procedure, the ESG, over time, if they're consistently putting more in their stomach than the space allows, that pressure over time can cause the tissue to dilate.
Got it. So if somebody has that done, is
Mhm.
that an in-office procedure, or is that something where you're actually I know obviously the standard bariatric have been, you're in the
Right.
hospital several days, what have
Right.
you. So
Right.
what is the framework on this one look like?
So this is done as an outpatient procedure. So the person comes in the morning, just actually, so where Sarah had her colonoscopy at the Ascension Hospital, St. John's campus, that's where I do these procedures. So just like you came in that morning, nothing to eat or drink the morning of the procedure.
Yeah.
You come in, you're pre-opt, you meet with the anesthesiologist, you do receive sedation, you do receive general anesthesia, so you're sleeping fully during the procedure. But I do the procedure and it takes anywhere from 45 minutes to maybe just over an hour. And then the patient goes to the recovery area, wakes up over the course of about an hour. And as soon as they feel well enough, get dressed and go home.
Walk on
That
out.
is absolutely remarkable.
Do you ever see
Wow.
any insurance covering those?
Wow.
So again, back to this whole it's new thing. No, that will be the case in a number, in the next 5 years, we will have these procedures covered by insurance, but right now they are not covered. And so it is an out-of-pocket payment that patients, choose to, when they choose to have the procedure.
So I do have to say, when Dr. Merritt was doing my colonoscopy, it's this whole uncomfortable thing in the room, but she had the music on and she came in dancing and the anesthesiologist was singing in my ear for a second. The other girl's like, do you like this song? I really thought I suggested Baby Got Back. And had something else on, but because I thought that was more with the theme.
More with the theme.
Yeah, but it was, it's
love
one of those awkward moments getting your colonoscopy.
Right.
And it's like, kudos to you and your staff, made it so fun. And that was the first thing I said. I mean, oh my God, she was so fun. I didn't care. They're like, weren't you embarrassed? I'm like, I don't know. I really didn't care. They were like, and that makes a difference. It really does. Because it is an awkward, surgery you have to go in there and have, but it is a must that you have to have.
Right. Absolutely.
And I have been to your practice before as well. I didn't know about you, but now I know about you and my records are there. So yeah, an amazing practice. You are with such a great group of physicians, really.
Very
And
fortunate.
I don't say that lightly. Really very impressed with Borland and Gruber. Yeah.
Thank you.
Yeah.
Thank you for that feedback. That's really nice to hear.
Absolutely. Yeah.
We have some nice comments. I see. I can't read them all.
I was going to say, yeah, we've had some great comments. Dr. Merritt is amazing. Loved this. So it's been so nice to hear from you and for you to share all this stuff. I mean, people need to know about it, whether they want to or not.
And Dr. Merritt, you do have a website. Is that something that you keep up to date and active?
Yes, I do, as, to the best of my ability. So back to, where we started, how do you balance things? Some things just, maybe don't get done, or website doesn't get updated. And it's a work in progress, but absolutely. And it's a great way to contact me. I try to keep everything uniform. So my website is Dr. Lindsey Merritt. My Instagram is Dr. Lindsey Merritt, and the same on Facebook, so that I can, have that consistency across the board. So I'm probably most active on Instagram, and would see, messages, anybody that wanted to reach out and have any questions or anything, I'd be happy to speak with you.
Yeah, we'll definitely post that. Your sister didn't even know you had a website. I go, oh my God, her website's so great. She's like, oh, I didn't know she had a website. That's family for you, right?
Exactly.
No, this was so much fun. I know this was awesome because I know you're crunched on time, and that's why we keep these to 30 minutes. It was so fun getting to know you, figuring out why you want to do GI. Now I have a whole on it, and all the PSA stuff that you had for females out there about, colonoscopies, weight loss. So informative, and everybody out there should be getting them. I mean, doesn't insurances, they remind people now, I think, like, hey, you're 45, let's get this done.
I should know that if insurance companies do that. I hope they do.
I did. Well, two of my friends plus my sister said it too. Yeah. She got her thing, but it's like you need to make your appointment for your colonoscopy when you turn 45, and it was like an 8-month wait. So I mean, people don't realize you can't just get right in.
Right.
You guys typically do push out a reminder, kind of just after you have a breast exam, right? And then the annual checkup. So yeah.
Mm-hmm. Yeah. Once you're plugged into the system, we do a great job of reminding you, when you're due again. But that first colonoscopy, just you turn to 45 and come on in.
And if anybody's wondering, I don't have to be back in for 10 years.
Yeah.
Me too. 10 years.
I got the good one.
That's good news. Best case scenario.
Dr. Merritt, thank you so much for
thank you.
And I think it's a week or two, I want to make we are going to have our youngest female on. Our youngest, I believe she's seven, I think 7 or 8. She's going to be our youngest one, and she's going to be on next week. Her name is Sawyer. We're very excited. Her parents are very excited. She says she wants to do this interview, so I cannot wait to have her be our youngest female. So I hope everybody turns in, and thanks for being here tonight.
Yes,
that's so exciting. I'll put that in my calendar.
Yeah.
Thank you so much again. This was really a pleasure to talk with all of you, and have a great night.
Thank you.
You're fantastic.
Thank you.
Bye.
Bye.
Bye.